Hello. Today I will be presenting on osteoporosis. My name is Samantha McCoskey. I am with St. Mary the Woods College in the Department of Nursing for class NU 550, which is Clinical Management 2 with Dr. Crystal White. So today's presentation is going to go over osteoporosis and kind of explore everything about that. Osteoporosis is a common yet underdiagnosed skeletal disorder characterized by decreased bone mass and microarchitectural deterioration of bone tissue. This condition contributes to an increased risk of fragility fracture. It significantly affects older people since the risk of fracture increases with age. Globally, osteoporosis causes more than 8.9 million fractures annually, with the highest number of the osteoporotic fractures occurring in Europe. The most severe clinical implication of osteoporosis is an osteoporotic fracture. This includes fractures of the hip, vertebrae, and distal forearm. So the next slides that we'll be going over will share the major risk factors, the underlying pathophysiology, the clinical manifestations, the diagnostic criteria, and the guideline-based treatment. So this is just an overview of my concept map with the pathophysiological insult of the imbalance in bone remodeling, estrogen deficiency, aging, and diseases. Risk factors being age, female gender, genetics, ethnicity, sedentary lifestyle. Um, Clinical manifestations being fractures, height loss, kyphosis, chronic back pain, reduced mobility. Some of the diagnostic criteria will include a DEXA scan, the FRAX tool, laboratory tests, and imaging studies. And then the guideline-based treatment we'll talk about, which is increasing calcium intake, weight-bearing exercises, the different medications that can be used for treatment. So risk factors for osteoporosis can be classified into two separate sections, which would be non-modifiable and modifiable. And the non-modifiable risk factors include age, since older people are at a higher risk of having the disease than young people due to thinner and weaker bones. Women are also at a higher risk of developing the disease compared to men, since they have less bone tissue and less and lose bone faster than men due to the changes that happen with menopause. Family history also contributes to the increased prevalence of osteoporosis since individuals whose parents have a history of fractures also seem to have reduced bone mass. Ethnicity also plays a role in increasing the risk of osteoporosis, with Caucasian and Asian women being at higher risk of having the condition when compared to African American and Hispanic women. Some of the modifiable risk factors include the abnormal absence of menstrual periods, low estrogen levels in women, low testosterone levels in men. Anorexia nervosa can also contribute to the increased risk of having the disease. A lifetime diet low in calcium and vitamin D can also expose one to osteoporosis. An inactive lifestyle or extended bed rest also tends to weaken bones, resulting in this disease. Smoking and alcohol consumption also increase the risk of bone loss and fractures. So with the pathophysiological insult, osteoporosis results from an imbalance in the normal bone remodeling process. This process involves two primary cell types, osteoclasts, which break down bone tissue, and osteoblasts, which rebuild it. Normally, there's a delicate balance between these activities, ensuring bone density remains stable. However, when this balance is disrupted with osteoclast resorption, outspacing, osteoblast rebuilding activity. One major driver of the imbalance is postmenopausal estrogen deficiency. So, estrogen plays a protective role in bone health by inhibiting osteoclast activity. When estrogen levels drop after menopause, bone breakdown accelerates, particularly in trabecular bone, which is more metabolically active than cortical bone. Aging also causes the osteoblast function to decline, making it difficult for the body to form new bone. So, this gradual reduction in bone building capacity further exacerbates the bone loss. Osteoporosis is considered a silent disease because there are typically no symptoms until the actual bone or bones are broken. In the late stages, clinical manifestations become more apparent. According to a study by Abar Almazan, fragility fractures are the hallmark of osteoporosis, with the most common sites being the spine, hip, and wrist. Vertebral fractures are also significant and can lead to height loss, kyphosis, and chronic back pain due to compression. These fractures not only cause physical discomfort but also impair mobility and increase the risk of subsequent fractures. So, hip fractures in particular are associated with significant morbidity and mortality, especially in older adults. So, the diagnosis of osteoporosis is primarily based on bone mineral density measurements obtained through a DEXA scan, which is the gold standard. So, the findings obtained are interpreted using T scores, and a T score of negative 2.5 or lower, that will confirm osteoporosis, while a score between negative 1.0 and negative 2.4 indicates osteopenia, a precursor state. And then the FRAX tool can be applied to help examine the 10-year risk fractures. This tool integrates clinical risk factors with bone mineral density to provide a more comprehensive risk assessment. Laboratory tests are also vital in ruling out secondary causes of bone loss like vitamin D deficiency. These tests include serum calcium, vitamin D, parathyroid hormone levels, and renal and thyroid function tests. Some imaging studies like x-rays can also help identify vertebral fractures, which may be the first clue to osteoporosis in an asymptomatic patient. So some advanced imaging like an MRI or a CT scan can also be used for more of those complex cases or when fractures are suspected but not visible on x-rays. So treatment for patients with osteoporosis will require um, I'm sorry, will require a multifaceted approach involving both lifestyle changes and the pharmacological approaches. So lifestyle changes are vital since they form the foundation of management. Patients are encouraged to increase their calcium and vitamin D intake to support their bone health. Weight bearing and resistance exercises are also recommended to improve bone density and decrease fall risk. Fall prevention strategies like home safety modifications and balance training will also be very helpful. Pharmacological interventions that can be recommended include bisphosphonates like alendronate or zoldronic acid, which effectively decrease bone resorption and fracture risk. For patients who cannot tolerate the bisphosphonates, prescribing the RANKL inhibitors like denosumab, or more commonly known as Prolia, the SERMs like ralixifene, or anabolic agents such as teriparatide or Forteo, or Ramasozumab or Evenity, sorry, I'm not really sure how to pronounce some of those names, is also crucial, especially in high risk cases. Regular monitoring, though, with the DEXA scans every 1 to 2 years will be necessary to ensure the effectiveness of treatment. And with some of those medications, um, have to be monitored anyway because you can only be on them for so long before you have to switch to something else. And then, so for my case study, I have a patient, Mary Johnson, is what I've named her. She's a 67-year-old postmenopausal woman who presents with persistent lower back pain for the past 3 months and reports a noticeable decrease in her height over the past year. She also describes difficulty bending forward and recalls a fall last year that resulted in a wrist fracture. Mary has a history of osteopenia diagnosed 10 years ago, though she did not receive follow up treatment. Her past medical history includes well controlled hypertension. Her family history is significant for her mother having sustained a hip fracture at age 75. Mary does, however, lead a sedentary lifestyle. She is a non smoker and occasionally consumes alcohol. Physical examination, she is noted to have lost 2 inches in height since her last recorded measurement. There is visible kyphosis of the thoracic spine, and tenderness is elicited over the lumbar vertebrae. So a DEXA scan that she would have had done reveals a T-score of -2.8 at the lumbar spine, confirming the newer diagnosis now from osteopenia to, in fact, osteoporosis. Her laboratory tests show normal calcium and parathyroid hormones, but her vitamin D level is low at 18. So for this patient, you would want to start with the bisphosphonates and see if she can tolerate those. And then if not, you would proceed to the next recommended medications if bisphosphonates are not tolerated. You would want to repeat that DEXA scan in 1 to 2 years, as well as the laboratory tests, and just continue to have her follow up with that care. She could also partake in the non-pharmacological interventions like the weight-bearing exercises, the lifestyle changes, being more active since she does tend to lead a more sedentary lifestyle. So my review questions: what is the most severe clinical implication of osteoporosis? What role does estrogen play in bone health and what does it inhibit? And how are findings on a DEXA scored and interpreted? And these are my references. So if you have any questions at all, I'd be happy to answer those. I'm sorry I'm not in class today. I had to get a full day in of clinicals to meet my requirement. So I hope everyone enjoys their break and has a happy holiday. Thank you.